of these patients, about 40% never needed admission. And the other 60% had the admission times dramatically reduced.
Welcome to the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Marco de Lima. Marcus is a hematologist and director of the James Blood and Bone Marrow Transplant and Cellular Therapy Program. This is a large, very important program because blood cancers such as leukemia and lymphoma are all too common. And the James is a world leader in blood and bone marrow transplants, which are referred to as BMTs, and also in cellular therapies such as CAR T-cell therapy. And under his leadership, the James continues to expand and lead the way, and Marcos will fill us in on 3 new and important steps forward: the new outpatient BMT clinic, a new cell manufacturing facility that increases the speed in which Marcos and his team can deliver CAR T-cell treatment to patients, and a really interesting and collaborative project in Brazil. Welcome back to the podcast, Marcos.
Thank you. This is long due, I think.
Yes, so great to have you back, and we have a lot of ground to cover, and you have some exciting news to tell us about. But first, I think it's important to help people understand a little bit of the kind of the history of BMTs and some of the advances that have come over the past 20-some years.
I would start by reminding people that we make blood inside our bones.
Yes.
Right? That's where we house. I always joke with my patients, if you break a chicken bone, you see bone marrow inside. That's what we have inside our bones, right? And that's where we make blood cells and red cells and white cells and so on. And traditionally, we've used bone marrow as a source of replacement for folks who, for example, had leukemia, which is a disease of the bone marrow. So we would transplant bone marrow from a compatible sibling, for example. So then we learned to use blood to get these mother cells or stem cells that are inside the bone marrow. We made them circulate in the blood. So that came blood stem cell transplants.
So that's easier to get blood than marrow.
To some extent. It's always, the donors are, we love donors, I should say, but it is a commitment either way. But yes, blood is less invasive, if you will. And then we also learned that we could even use placental blood. It's full of blood stem cells, so there are cord blood banks out there for transplant. And then most recently, generally speaking, we learned that a bone marrow or blood is a somewhat blunt instrument, right? You have all these different tribes of cells there. Some are good and some can cause side effects. So the trend over the last decade in the field has been to separate these tribes and try to be more specific, trying to avoid side effects. And then most recently, even about a decade as well, we've been using these tools for genetic engineering to teach some of the cells that are derived from blood, therefore from the bone marrow, to attack cancer. Right? This has been very much in the news even, right? As we know, the chimeric antigen receptor cells, which CAR T-cell, CAR T-cells. And these are very much engineered cells.
So you take the cells from somebody and in a lab genetically re-engineer them to make them more efficient.
I may have used this expression before here, but we call them serial killers. Mm-hmm. Or you essentially teach them to recognize a structure in the cancer cell, and those cells now all they do is seek and destroy such structure. So they come very educated in the sense of being more specific in their killing.
So everything you do in BMTs and CAR T-cell, it's helping the body recognize the leukemia, lymphoma, the blood cancer cells that have previously been hiding. And over the years, it sounds like you come up with better and better and more ways to help the body's immune system do this.
Absolutely. Yeah. Ultimately, right, the bone marrow transplant is the oldest form of immunotherapy therapy for cancer.
Oh, that's a good.
That's the first attempt and the first ongoing attempt, right, at using a immune system, usually, as you said, a donors, to attack cancer.
Wow,
So
I hadn't thought of it, that it's the oldest first form of immunotherapy.
absolutely. Although now we have all those different forms of immunotherapy, but the first one has been this allogeneic, which means donor transplant. Yeah.
Okay, that's the donor, and then the other one, I always forget the
Yourself.
Yourself is
autologous.
the autologous.
Yes.
Okay.
Yes.
Okay, so good.
No.
That's a great background. And so now let's talk about some of the new things.
Aha.
And let's start with the new outpatient clinic, which is, to me, sounds a little bit revolutionary. So explain kind of the need for an outpatient clinic and then how it will work and how it will help patients.
Traditionally, right, all these treatments have been done inside the hospital, right? I mean, the patient would be admitted, say, today, and stay anywhere from 3 to 5 weeks. And then
in isolation?
In isolation, or at least relative isolation, right, with few visitors and can't leave the floor, sometimes can't leave the room.
Yeah. It's because they don't want any chance of infection, or?
To some extent, but also because of care delivery, right?
Okay,
I mean, the structure and the needs are multiple, and I would use the word traditionally. This has been set up as an inpatient care delivery. Then a few things changed, right? I mean, our ability to prevent infections has improved, by new medications and other approaches. We also learned to use safer chemotherapies, and the recovery is a little faster. So all this prepared the stage for us to consider, hey, can we not even admit this patient? I mean, can we try to stay outside, throughout this journey?
Throughout the BMT process.
Throughout the BMT process, or the CAR T-cell treatment process. And that's what we're proposing, right? I mean,
so it took, I don't know, 20, 30 years to get to this point where it had progressed enough that you thought
it's safe. It's safe to do that. And of course, it is an approach that may not fit our families or our people's situations, right, in terms of social support and caregiver support, but in some cases it might. So it's a combination, right? It's the technology, but also a very important, in our view, option for folks for whom this may be right. So of course we're going to continue to offer inpatient, right? I mean, this is the backbone, if you will.
Right.
But we certainly want to start expanding the option of, hey, maybe I want to try to do this. I'll come here daily instead of being in the hospital. Then I go to my own bed at home and come back tomorrow. And so that's the spirit.
Okay, we're going to take a quick break, and when we come back, Marcos will fill us in on a few more of the details of how this outpatient clinic is going to work.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Marco de Lima, and you started talking about the outpatient clinic, and let's dial down a little. Give me, where will it be, and sort of what kind of staff and services will you be able to provide to patients?
This type of treatment, right, is multidisciplinary by definition. What do I mean by that, right? I mean, you have a doctor, but you do have, or you do need a nurse,
yes.
Right? It's probably the cornerstone of all this conversation is actually nursing. We have advanced providers such as APPs and nurse practitioners and such.
What are APP? Advanced practitioner.
Advanced practitioner, yeah.
Okay.
And we have nutritionists, right? Physical therapists. We can go on forever, right? So it's a multidisciplinary team that normally is available inpatient. So now we're extending at least a part of this large group of people to be available Saturdays and Sundays. Includes a pharmacist as well, the blood bank. So as you can see, it's basically the same functions, if you will, that you would be providing inpatient. You try now to provide those over the weekend to some extent, at least.
Because when patients need something, they need it.
Exactly. And if you are willing or planning as we are or executing as we are to have some of these procedures now as much as we can outpatient, right, to minimize the time in hospital, you do need to provide all the services. So to hopefully assure that these people never need to be
put
inpatient.
Inpatient.
Yeah.
Now, you mentioned before that not every patient this would work for. So either what about the patient themselves or the type of cancer they have would make them better candidates for outpatient BMT and CAR T-cell therapy?
Yeah, the first thing is obviously what the patient wants, right? I mean, what he or she feel comfortable with. Second, I think, never forget the caregiver.
The unsung heroes of cancer therapy.
Yeah, absolutely. So we need those, right, to be assured that this person can come back and forth and so on. And finally, the way we are organizing this initially, we will offer this for CAR T-cell treatments. I should mention that, by the way, we've done already about 20, maybe off a little bit, patients that received CAR T-cells on an outpatient basis.
Oh, okay.
Yeah, we've been doing slowly but surely building this up. And of these patients, about 40% never needed admission. And the other 60% had the admission times dramatically reduced. They needed a little bit of admission, but not the usual, say, 10 to 15 days that CAR T-cell patients stay in the hospital.
Well, let me see if I've learned from you, from what you've told me in the past. Perhaps is the reason that this is working with the CAR T-cells because it's their own cells they're getting back, so they may not get the graft versus host disease that you can get if it's donor cells.
Exactly. And although they have their own set of different side effects that we have to monitor for, they also allow us to exactly be a little more liberal in that aspect of keeping them outpatient. So we do have some experience. It's not that this is totally new for us.
So you know it works because you've done it.
Yes, and we obviously want to increase that percentage that we never see the inside of the hospital, we hope. So basically the initial populations that we're going to target will be CAR T-cell recipients, or some of them, and recipients of autologous or self-transplants, which usually are done for multiple myeloma.
Oh, okay.
So those are the initial target populations that we're going to hopefully offer this type of treatment.
Now, it's interesting you say multiple myeloma, because I know from talking to you and Don Benson and others that it's a fairly rare cancer, but because the James is known worldwide as such a specialist, you get myeloma patients from all over to come here. So that's important to be able to do that on an outpatient.
Yeah, I mean, to give an idea, we, under the leadership of Dr. Benson that you mentioned in treating myeloma, we perform about 150 autologous transplants for myeloma every year.
Which is probably one of the highest in the country.
Yeah, you oscillate a little bit between 150 and 200. So these are large numbers of folks, right? As it is today, they are all inpatient for their journey. So we, as I mentioned, aim to reduce that, or hopefully even for some patients, completely shift it to outpatient. And the reason I keep saying decrease because we envision that some patients will be outpatient, and then if they need, they go inpatient. But the net result that we envision is either no admission or a much shorter admission time.
As
right?
needed instead of throughout the process.
As predetermined, as it is. We will be doing this on the 5th floor of the James, where we have our infusion area. That's where we have our BMT clinic as it is already, so that the facilities will be the same. And patients will be seen there. That's where we're using. It's the same setup that we have now. It's just opening on Saturdays and Sundays as well.
And okay, now CAR T-cell is growing here and worldwide and is really a game changer. And another change to the game, you're now, instead of having to send the cells from somebody to a lab somewhere in the country, you're now going to be able to manufacture them yourself. So first of all, how do you manufacture them,
right.
and what does that mean that you'll be able to do it yourself?
So currently, right, so you collect the so-called lymphocytes from a patient, send them to a company, say in New Jersey or the West Coast, and those cells are genetically manipulated and sent back to you frozen, right? So that process can take anywhere from a few weeks to 2 months, depending on insurance approvals, the time to actually manufacture the cells, quality control. So let's call that centralized manufacturing. That has been incredibly successful, right? Led to this revolution we're seeing, but it also has its limits. As I mentioned already, 2 months sometimes is too much.
Right, a
2
patient
months,
needs treatment fast.
You're measuring chemo, right?
Yeah.
Time in our business, sadly, is measured in chemotherapy. So there are serious advantages if you can change that paradigm again and bring manufacture closer to the point of care. So this is something that philosophically we've been investigating. I've been involved in initiatives with this for almost a decade now. And the idea is that that's simple, is we make it. and in order to
you say simple, but I have a feeling creating a lab and genetically modifying cells might not be simple.
No, it is not. But we're trying to simplify. Let's put it like that. It involves, as it is, the utilization of a genetically modified virus, right? That's the tool, the engineering tool. Because people ask me that, how do you make those genetic instructions get into the cell? And those genetic instructions get into the cell by virtue of a virus. And said virus is also engineered to insert the genetic instructions. So there are several steps.
But you genetically engineer the virus to take rid of the bad part, get rid of the bad parts of the virus, and keep the good parts.
Exactly. So you sort of hollow out a virus, insert genes that you want, and then let the virus do its thing, which is to get into the cells. And because remember, viruses are professional parasites, right? I mean, they don't have a cell. They need to infect. Remember the COVID virus, right? And they needed to infect a cell, inject its instructions there to make more COVID virus, because they can't do it themselves. So the ultimate parasite. So that system, if you will, is a perfect tool to inject genetic commands. Does that make sense?
Yeah. And so you need a team of, I don't even know what the job title would be, scientists who do this.
Yeah. And then when you have that tool, basically you co-culture, put in culture my cells and the virus, and then after a while they magically are doing what you want them to do.
So when this is fully up and running, how do you foresee the time? How much time will it take? Instead of up to 2 months, it could be
For us, currently, we have treated now 14 patients in this ongoing clinical trial, of which it's taken us 7 days.
Wow.
Yeah, 7 days from collecting the cells to giving them back to the patient.
And that means a lot for a cancer patient in terms of the spread and treatment and killing of the cells. That
we
can
think so.
Save a life.
We think so. I mean, it's so the same concept we're trying to. Well, actually, I shouldn't use the word trying. We are expanding it because, again, as I mentioned, for now, it is within clinical trials, but we're gonna be opening another 2 clinical trials very soon, and expanding this for now for blood malignancies. But the goal is to reach very soon solid tumors, and our first target under the leadership of our PIIO leader, Zihai Li, will be a CAR-T targeting glioblastoma, a brain tumor. So this will also be manufactured in-house and delivered very fast.
Wow, that's interesting because, and you'll fill me in, but I know that CAR T-cell right now is for blood cancers.
All the approvals are in blood cancer for now. There is no product yet for solid tumors. And
that will be a tremendous step forward.
Well, we hope so. It's coming to a theater near us.
And you've already created the lab facility to re-engineer.
Absolutely.
Wow.
And Dr. Zihai Li, we're working with him very closely to have this project reaching patients. We are aiming for the beginning of next year. But this will be totally in-house, from the tool development, from the target that we're targeting, and the manufacture of the CAR T cells. The whole cycle will be developed and produced at OSU. So it's pretty impressive.
Yes, definitely.
Yeah.
Wow. So the third element that we wanted to talk about, that you're working on a project in Brazil that I don't know too much about because I think it's fairly new, but fill us in.
So there are 2 things, right? I mean, before I get to the Brazil, and you see why these things are related, we are in the process of expanding our ability to do all this, right? So we need a little larger, shouldn't say little, we need a larger laboratory footprint.
Reaching more patients, you mean?
No, I mean the laboratory to be able to manufacture cells and to process cells and things. So the idea is to use our Polaris campus, where we have a lot of space there, where we have contracted with a company called Germ-Free. So Germ-Free is a national leader in producing mobile clean rooms. So imagine a container-like structure in which you load all your gizmos, all your PCR machines and high-tech stuff. But this container is potentially mobile. Could be even on wheels if you want, but it's not. In our case, it's not. And these prefab structures will be placed in Polaris that will allow, these are clean rooms, so meaning you have to gown up, the air filtration is, there are some very specific specs in terms of how many particles can be in the air and things like that. And this will be a fairly large facility. It's a very large investment that OSU is making. And this will be, as I said, in Polaris. So, meanwhile, we've been partnering for many years now with an organization called Caring Cross. So Caring Cross is a very interesting NGO, non-governmental organization, that has a mission to take gene therapy and cellular therapies to those who cannot afford it. So that's their stated mission. And you may say, wow, that's an interesting, right? I mean, and we thought it is interesting. So these folks have a strong background in manufacturing viruses. So that's where they came from industry-wise. And the idea here is basically get this concept of a mobile clean room. They'll bring one to us here. So it's another one of these clean rooms that we're going to get from Caring Cross. This one comes attached with an agreement with the Brazilian government, where the Brazilian government is contracting with Caring Cross for two things: CAR T-cell manufacture and virus manufacture. So it's a tech transfer agreement between Brazil and Caring Cross, by which Brazil is going to be able to do those things: manufacture the virus and manufacture the cells.
Okay.
The modular mobile clean room will be the unit that similar units will be shipped to Brazil.
Similar to the one that's going to be here.
Similar to the ones we're going to have here. And where do we come in? So OSU, in turn, is in agreement with Caring Cross. So it's a triangle, if you will. We're not directly contracted with the Brazilian government, but we're contracted with Caring Cross. So what we're going to provide here? We're going to provide expertise. We're going to provide training for the Brazilians in the unit that's going to be provided by Caring Cross. And we're going to also, we're already piloting the initial constructs, the initial CAR T cells that are going to be provided ultimately to Brazil. So we are piloting those studies here. Wow. So it's a very ambitious program with the final goal is to provide CAR T for free within the Brazilian public care system.
Oh, wow.
Yeah,
for
this is
free.
going to the Brazilian government, not a Brazilian company. It's a Brazilian government, and it's going to be providing their public care system there. So it's going to be the first, free, everything is relative, right? But to the patients in Brazil, it's going to be free. It's the first free CAR T cell in the world.
Wow. Now I have two questions. I'm trying to envision this unit, the modular unit. Is it like stand by itself outside, or is
yes?
It's
it
too
could
big.
It could be within a big warehouse.
If you had because it's big.
Some people have done that. Some people have even built structures to protect it, extra protection to it. But essentially, it's about the size of a container.
Okay.
I mean, a ship container.
So that would be hard to put inside the James.
It's a large thing. Yeah. For example, there is one of these that was placed on top of the NIH building.
Oh,
yeah,
okay.
Because they had the same issues with problems. And so these units are popping everywhere. You can imagine why, right? Because it's practical and it's cheaper than brick and mortar, although it's not, I wouldn't call it cheap, but it is cheaper than brick and mortar. So that's how we're going to start our expansion.
Wow. Now, my other question that I thought of while you were explaining this, is this a coincidence it's Brazil? Because you have a Brazilian heritage and connection.
Well, yes and no. I think I probably helped facilitate this conversation in Brazil. But honestly, the cornerstone of this is this organization, Caring Cross. You know, I would say my role is secondary, but yeah, you're right. There was
but it must be kind of rewarding.
Yeah. Oh yeah. But we are very ambitious in this conversation because philosophically it fits right in with our program's ideas, right? Which is to bring manufacture back to closer to the patient. So this is the ultimate concept, right? I mean, the Brazilian project initially will be 2 units that will be placed in Rio de Janeiro. So we have visited the locations there, and subsequently they're going to plop units all along the coast in Brazil. Wow. So there will be several centers, again with the concept of bringing manufacture to closer, not to centralize, it's to decentralize.
It sounds like a model that could catch on in other countries.
That's the ambition.
Yeah.
That's the ambition. We are at the same time in conversations with a group in Kampala, Uganda, in the where by which we would be doing similar ideas, similar concepts of training and cross, sharing experiences with the group there. This one is in the capital, Kampala. So anyways, yeah, there are conversations going everywhere.
Wow, so that perfectly leads me into my final question, which is, to kind of put this all into perspective, over the course of your career, your ability to help and have better treatments for patients has grown exponentially.
Yes.
What's that like for you to be able to treat patients and lead the program here at the James and offer better outcomes for patients?
It is as cool as it gets. It's probably going to postpone my retirement. I've been long enough in this building, or in this line of work, to say that if you ask me, when I started as a faculty, year 2000, at MD Anderson, this hospital in Houston, that I would be discussing gene therapy, so matter of fact as I am with you now, I would laugh at you. I would say you're on drugs or something. And here we are, discussing this. And listen, before we go, we're not even mentioning that just this past week, I prepared 3 patients to receive gene therapy for sickle cell anemia cure. Oh yeah, we're talking about sickle cell cure, and I don't hesitate to use the word cure. We're talking about tumor-infiltrating lymphocytes for solid tumors, which is a form of cell therapy for solid tumors, not CAR-Ts, but yet cell therapy. And this is all happening as we speak, and a lot of these things are FDA approved already. This is not even research. Gene therapy for sickle cell has just been approved by the FDA. Oh yeah, so we're going to have our first patient very soon.
Wow, that's you surprised me with this new project. Wow, that's pretty amazing.
No, that's how these things are branching out, right? Because here we are talking about blood cancers, and you remember when we first met, it was all blood cancers.
Yeah.
Well, now in 2 seconds, I already told you there is solid tumor cell therapy, and there is now sickle cell gene therapy, thalassemia, which is another anemia, no cancer, but a very serious disease called thalassemia. It's another form of anemia, also has a gene therapy approved. So this is a new era.
So this whole concept of genetic engineering of cells is going to continue to grow.
Yes.
Wow.
Yes, it is as we speak. I mean, you remember when we first met, it's not even a year and a half, right? I mean, how many things are, yeah.
All right, well, we covered a lot of ground.
Thank you. Yeah.
Thank you for filling us in, and good luck in all these projects. And,
thank you, sir.
And I think if we talk in another year and a half, you'll have 5 new things for us to learn about.
I hope so.
All right. Well, thank you.
Thank you, sir. Thanks for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.